I'm going to go off script here just for a moment while I'm getting the clicker. You can tell by the pervasive green of my opening slide that if you have not yet heard that the American Nurses Association sold NDNQI to Press Ganey, now you know. One of the things about NDNQI is that ANA wanted was to have the data available to researchers everywhere to conduct research and there was a fee for that, and Press Ganey has agreed that they will do the same. So access to NDNQI data will continue for research purposes. Okay. My topic today is how do you develop indicators, valid and reliable indicators, and so I'm going to talk about the general case, and then I'm going to talk about national specialty certification. So we collect data from two sources, two data streams. One is clinical and staffing data that are collected quarterly or reported quarterly, and these elements, data like staffing measures, pressure ulcers, falls, infections, come from a variety of systems, including payroll or staffing systems, patient census, human resources, or unit managers. And I want to pause there to say, and that's where we get the education and credentialing data for quarterly data collection. Chart reviews, e-medical records, prevalence surveys, incident reports, infection control, special logs, et cetera, et cetera. So they come from a variety of sources. We just did release our first e-measure on pressure ulcer incidence and prevention measures. And to my great relief, 9 hospitals reported data for the second quarter of this year. And so it was a 2-year, incredibly intense process with Judy Warren to develop these measures, and the guidance document for collecting the standardized data out of EHRs was, I don't know, 60 some pages. And the fact that 9 hospitals made their way through it in the first quarter was, I thought, a really good sign. So our second data stream comes from the annual RN survey, and it's eligible RNs are in hospital units who've been on the unit for at least 3 months, because apparently we believe that if they've been there less than 3 months, they don't have a valid opinion of satisfaction. It's the honeymoon period, and that they spend more than 50% of their time in direct patient care. And we ask a variety of education and certification and credentialing questions on the survey. So these are the major activities in measure development. A literature review, these are pretty standard, they follow AHRQ and everybody else. So literature review, discussion with experts to find out what you can find out about what they know about measurement tips and reliability and validity, collateral data that you want to collect as well, such as risk assessment or the degree of severity of an adverse event. And then you draft the initial guidelines and data collection forms, do a pilot study, one short little line there, and then revise the guidelines and forms and build data capture and reporting systems. And then monitor and test. One of my big themes is you never stop checking the quality of your data. So for identifying, the first step is to identify a measure area and existing measures. For certification, there are many existing measures, and so the first step clearly is to identify what you want to know, what your research question is, what's the theoretical framework for assessing or using this indicator that you're developing. On every measure we develop, we start out with the aim that we will be reporting it to NQF for potential consensus adoption. And so we look at importance to measure and report reliability and validity. If anything exists before we start collecting it, and things like gaps, performance gaps, differentials, et cetera, and usability and feasibility. So we also look first to the National Quality Forum and to the ARC National Quality Measures Clearinghouse to see if there are existing measures to begin with. Almost all measures that we find are at the hospital level, and since we look at the nursing care unit as the unit of analysis, and we do structural analysis, we do like health services research. And so we don't look at individual patients or individual RNs. We look, for example, at the prevalence of certified nurses on a unit or in a work group. So lit review, draft guidelines, expert review, revisions, cycle till you find like you're satisfied that you can go forward to the pilot test. So you draft your first set of data collection guidelines, including the proposed numerator and denominator, inclusion and exclusion criteria, potential collateral data, and any information you've got on reliability and validity. And this is the pilot test. Finalize the guidelines, recruit a sample, do training on data collection, collect the data, debrief the sites on what the problems and issues were or what was omitted that you should have been collecting. And most of the time they have a lot to say, and then analyze the data and then start to put it into your Dunton model to see if it operates as anticipated. So then before we start to build it out into the data collection section, we confirm that data sources exist from the pilot study, that the data can be collected in a standardized manner, that the respondent burden is acceptable, which is where EHRs come in, or I like to think of it more as the hospital's health informatics warehouse, and because there's so many sources for data right now about nurses instead of just one, and that the guidelines were clear. So then you finalize the guidelines, create the web tutorial, which we always have available for hospitals to take the tutorial and pass the test with 100% on the important criteria before they're allowed to enter the data, and then hold the teleconferences for trainings. We're also always available for questions, which hospitals are not shy about asking. Then, post-implementation, we do our standard quality assurance process for missing or out of range or inconsistent data. We track particularly a new variable for large variance over time, which could be a small sample situation if not many people report to begin with, or it could be just a very rare indicator, or it could be problematic in some way, or there could be large seasonality. Then we ask the hospital liaisons who talk to the ND and QI hospitals what questions they've received about clarification on the guidelines. So we really, go from version 1.0 to version 1.2 pretty quickly. And then we keep track of reports of data that are not readily available. We do find that different numbers of hospitals, different numbers of units report more fully on one indicator rather than in others. For ND and QI, the most commonly reported indicator you would think would be staffing. No, it's false. And then staffing is second, with sort of downward progress from there. And then we do an analysis of nursing sensitivity, put the data into a multi-level model, estimate, test to see if the variable performs as predicted in the Dunton model, and then decide if it's, again, related to nursing, and so in some aspect of the nursing workforce, which would include credentialing. So, and then we do reliability and validity studies after the data have been collected and reported for at least a year so that data collection is stabilized, and do some kind of, depending upon what the measure is, inter-rater reliability or rater to standard validity or signal to noise reliability, and then we're ready to submit the indicator to NQF. RN specialty certification. We collect the data both on the clinical and staffing measure side and on the survey side in slightly different ways. Hospital-employed RNs who spend at least 50% of their time in direct patient care, the data can come from human resources per the guidelines, but we find, in fact, that most sites have, the site coordinator talks to the nurse manager to find out about current certification of RNs on their unit. And then we count RNs with certifications. We don't count certifications because RNs have multiple certifications. And so we count the certifications as standards set by a nursing specialty organization, granted by the same nursing organization with a current certification. Exclusions are employer-based competency or certificate granting, completed courses in ACLS, PALS, etc., certification granted by multidisciplinary organizations that are not limited to nursing. So what we're going for is credentials for clinical nursing for clinical practice. On the survey, we have evolved our data collection over the years so that we ended up deciding that the best strategy on the survey was allow RNs to say yes to what they want to say yes to. So, and so we asked them about education. What's your highest degree? Do you currently hold any of the following credentials? And so we've got the competence or certification awarded for by a hospital for some technique. I just found out what a bloom pump was yesterday. It doesn't sound like a basic thing to me. Basic life support. Guess what?
I remember them.
Sometimes nurses. So basic life support provider is ACLS or PALS. Advanced credential or competency. And then fourth, we ask about specialty nursing certification awarded by a national nursing credentialing association. And then we give examples. So they've got to go through all of these questions to get to the certification question. And when we started out, we had an other fill in the box. And so we found people saying, when you ask them about nursing specialty certification, they would write in RN, or they would write in a lot of ACLS, BCLS, or BLS. And so, and they would write in certifications that had to do with management or finances or other kinds of things than clinical practice. So we ended up with then a questionnaire flow that says, if you say yes to I have a national specialty nursing certification, they will have a pop-up box appear where they click on which nursing organization granted the certification, because it turns out they're more likely to remember that than they are the acronyms for their certification. And then once you check the organizations, the certifications for that organization appear with both written out and the mnemonic letters. And so then they get to check which one they're certified in. They can do this for any number of times for all of the certifications they hold. So one of our testing practices over the years has been to compare the quarterly data on certification with the survey data on certification. Quarterly data is certified, yes, no. Survey data is in what? And so initially we found that the survey data was 8 to 10 percentage points higher than the HR data. Everybody automatically believes that's because HR is not as up to date as the nurse reporting on her certification. And then we started these revisions for asking, questions in a sequence that would allow nurses to say yes. And we found actually that over time, the gap narrowed so that now the measures are virtually identical, and the survey came down to the HR/nurse manager reported level. So they're very, very close. Now, with a mean at about 25%, and there's a correlation between percent certified on a unit between survey and quarterly data of 0.77, and we still monitor the other category. Before we get to lessons learned, let me also say on testing, we have over the years used both quarterly and RN survey certification data to see if it was related to any nursing outcome or nursing process that we collect, and almost never found anything. If we did a model in sort of a stepwise fashion and we entered certification in there, sometimes would be an association, for example, with pressure ulcers. But then when we added in education and years of practice, the certification would become insignificant. So one of my questions has always been, what is it? What is it that's certification? And the nurses around me gently said it's specialty knowledge. And so the one time, or we've found an association several times, but the strongest association we have seen was with two particular specialty certifications and bloodstream infections. And those were a critical care association and a cardiac care association. So for post-transplant, post-whatever, got bloodstream infections. Okay, I'm flashing red here. Okay, so my recommendations: standardize, get detailed definitions that are driven by the purpose of your study, allow RNs to say yes if you're asking them questions, and maintain quality assurance and keep testing. Thank you very much. Very nice, very good. Thanks.
Thank you, Nancy. Our next and final panelist is Patricia Brennan, and Patty will be speaking on innovation. Patty.
Oh, I have to control something.
Innovation and certification, keeping up with the future. Patricia was the Lillian Molman Bascom Professor, School of Nursing and College of Engineering at the University of Wisconsin-Madison. She is currently the National Program Director of Project Health Design, which is a Robert Wood Johnson Foundation-funded initiative designed to stimulate the next generation of personal health records.
Thanks very much for the introduction.